So this is a real world study. So, I think that the reason to look at this is that one of the things I've been struck by as a leukemia doctor, practicing since 2017 and on the faculty, is that there's been a transformation, even from the time that I started my fellowship to now, in terms of how we treat acute myeloid leukemia. And a lot of that is because the increasing use of venetoclax. Venetoclax is an oral BCL2 inhibitor, and before venetoclax, we really did not have very effective therapies for older adults who were unfit for intensive chemotherapy. We had single agent hypomethylating agents, for example, with relatively low rates of response. So with the use of venetoclax, all of a sudden the clinical trial data were showing, and it's been borne out, and as we'll talk about in the real world experience, that we can achieve really remarkably high rates of response, all of a sudden going up to at least 2/3 of patients achieving complete remissions, and about a year and a half, of a duration of response. And so that's already exciting. Obviously, I think we can still improve further. What we wanted to do in this real world study is to better understand, how this therapy, first of all, is being used in real life, and how does it compare to similar patients who receive more standard therapies. So what we did is we have this is a multi-center, very large chart review study, retrospective multi-center study, sponsored by AbbVie. But we're so excited because we have over 500 patients that we've now collected this data on. It's a very large, series of data, and with a lot of detailed annotation, which we had built in as we designed the protocol a number of years ago now. So we have about 267 patients treated with venetoclax combinations, and a similar number of patients treated with non-venetoclax treatments. We've matched the patients by age group and by ELN risk stratification. The poster that I'm presenting here at ASH focuses on the subset of patients who are unfit for intensive chemotherapy. We use the Ferrara criteria, which basically looks at the age of the patient and also the presence of significant comorbidities. So these are patients who should not be getting intensive chemotherapy, and so we were able to take those patients and match them to patients who receive standard therapies, including some patients who, on the matched cohort, who actually did receive intensive therapies. The take-home message, looking at the subset of patients, so again, who were ven-treated patients with unfit for chemo, about 102 patients matched to same number of patients. There were some patients treated, again, with intensive therapies, similar outcomes. So that was actually really interesting. There wasn't really a difference. About 67%, which is pretty much the exact same percentage in the clinical trial, achieved complete responses. What is different, and this is what we were talking about, is that there's been a paradigm shift in where the care takes place. So intensive chemotherapy, of course, is done in the hospital. And people have to be admitted. There are a lot of adverse effects. They go through severe cytopenias, risk of infection, and hopefully recover their counts, discharged. Venetoclax, while it may be started in the hospital, our clinical experience is that it's often then continued outpatient. So we wanted to quantitate this. So this part of the ARC initiative, we looked at healthcare resource utilization, and we were able to specifically show there is a significant difference, understandably. And patients who were treated with azacitidine plus venetoclax or HMA plus venetoclax were spending less time in the hospital, per patient per month, and have a much shorter duration of hospitalization than patients, for example, who were treated with intensive chemotherapy, which makes sense, but we're able to actually see that for the first time. Now, what we are seeing is that there are more outpatient visits, for the patients who are treated with venetoclax, which makes sense. But we've been talking about this, and I think, of course, from a patient perspective, it's still better to be out of the hospital, to be able to just go to your clinic, then go home, than to be stuck in the hospital. And then at least thus far, seeing similar kind of outcomes. So I think this is still very provocative. I'm not here to say that it's a better thing to do for a patient who's fit for intensive chemotherapy to give a non-intensive venetoclax treatment regimen, but there are randomized studies that actually are looking at that question. When we did look at the subset of patients who were matched to non-intensive, non-venetoclax therapies like single agent azacitidine or decitabine or lotocytarabine, which is harder to find these days. We had to look back because as soon as you introduce venetoclax, people are not really using that. But when we did look at this, of course, there was superiority of the HMA venetoclax in terms of response rates and survival. But that's really what's borne out in the clinical trial. So what we're trying to do with this real world study is go beyond what we can see in the clinical trial data.